I'm Alex Smith. I'm Associate Professor of Medicine in the Division of Geriatrics at UCSF. I'm a physician researcher and my clinical background is in palliative medicine. And my research focus is primarily about prognosis in older adults. So in my clinical training in palliative medicine, it was primarily focused on people with cancer and a lot of younger people. And when we would have consults from older adults who had dementia, multiple chronic conditions, organ failure of one type or another, we were somewhat at a loss about what to do. And yet that is by far and away the biggest and growing need in terms of palliative medicine approach to older adults in the United States. So I recognize there's giant disparity between the training and the need. And as a budding researcher, I decided this is sort of the area I want to focus on. So how can we improve care for older adults who are living with serious illness? So what is E-Prognosis? E-Prognosis is an online compendium of prognostic calculators. It's designed for clinicians to use. All of these calculators are publicly available, published in journals, and yet sort of languishing for the most part and not used. So we realized, hey, if we make these easy to use for clinicians, then maybe they'll start using them in clinical care. They're easy to use drop-down menus. They have information about the population in which the prognostic index was derived and validated, information about the accuracy of the particular prognostic model. And then you can calculate and you get taken to a results page which sort of clearly displays what the likely prognosis for life expectancy is for these folks. But we're very interested in whether patients A, want to know this information, and B, want their doctors to talk to them about it. Our first sort of foray into this was Paula Spann at the New York Times publishing a paper saying, if your doctor had a prognostic calculator, would you want them to share that information with you? And in the comments, hundreds of comments, and 99% of them said, yes, absolutely, I'm entitled to this information. I should have this information. But those were the readers of the New York Times. This is not the average patient population. So we, in San Francisco, we conducted a survey of 65 older adults, and this is quantitative and qualitative study. They spoke English, Spanish, or Cantonese, very diverse population, older adults who had disability, living in the community. Said if your doctor thought that you had about 5 years left to live, would you want them to talk to you about it? I found that 2/3 of them said yes, they would. And they had good reasons for saying they want to know. It would help me prepare spiritually, financially. I could tell my family. Does this mean I should change the way I'm living, exercise more, exercise less, move in with the grandkids. So from the patient perspective, it was really important that they have this information so they could make life decisions and sort of life planning. At the same time, there was a substantial group of patients who said they don't want to know, and they also gave very good reasons. It might make them depressed, they dwell on it. It would be more likely to come true if their doctor told them. So we've sort of argued since then that doctors should offer to discuss life expectancy with older adults, but they should respect those who don't want to talk about it and understand their reasons, and also engage in those discussions for patients who do want to know, and caregivers, I should note, who are an important part of this, because they're involved in that planning aspect as well. There have been other groups around the country who have done other surveys suggesting that the proportion of older adults who want to engage in these discussions may be lower when you're looking at long-term prognosis. But I think all of the data sort of agree that there's a substantial proportion who are interested in these discussions, and there's a substantial proportion who aren't. And that the truth is, what the exact split is, 60-40, 40-60, whatever, I'm not so worried about. But because there is such a substantial proportion who do want to engage in these discussions, I think it's physicians' obligations to at least offer that information.